So I'm going to start by giving context to this whole issue of why we're even talking about fetal pain. As many of you know, if you trace back ever since abortion has been a reality in North America, the objections to why we should have any interest at all in the preborn, may have begun first with the statements or claims that no, it's just not, the fetus isn't a human being. But once we became a little bit more enlightened scientifically, especially with the rise of imaging techniques in science and medicine, with ultrasounds. I think it's safe to say that the goalposts have shifted, and nowadays the biggest claim, or the claim given, is a little bit more loosey-goosey in that those on the pro-abortion side would claim that a fetus is just not a person, whatever that may mean. But the whole point of bringing up pain, actually, and this is topical because actually in the US, approximately 12 to 16 states have brought about legislation protecting children, or the preborn, beyond the 20 weeks gestational age because of their what's called pain capability. So this is it's not an issue that I think has the interest and has been taken up as a legislative cause in Canada whatsoever. But I think it's a new, as we call it, a new wedge issue. The term wedge in the whole pro-life area is one that there's some controversy. It's part of, you can be absolute about pro-life issues, or you can be a bit more pragmatic and take what's called an incrementalist approach. And I'm not staking a claim on either side. I think many of us and here are absolute in our conviction. But in terms of capturing the interest of the public, maybe to gain a foothold, either scientifically, to again put another reason forward for our interest in the preborn and as to why we should protect them. The pain issue is, I would say, a good one. It's one that I'm going to tell you capitalizes on the society's deference to science. So that's what we're going to be focusing on today. The reason that I think pain has become more of an issue nowadays is because of the way secular bioethics has been going. I'm going to mention a few people, a few key players who have been very influential in secular bioethics. And we could, because they've turned the tables on in terms of seeing what is important in a particular living organism, we can use their emphasis to our advantage. And that's what I want to basically point out today. Because although at one point, if you grew up in a Judeo-Christian culture, your moral status was based on your membership or your being a human being, that's not so true anymore. And certainly if you look at bioethics literature, it's almost taken for granted that just because you're a human being doesn't necessarily grant you any rights or moral status whatsoever. But as you can see here, I put pictures of dolphin and pig, who, in this day and age of people, I think rightly being a bit more concerned about the status of animals, how we treat animals, there's a new way of bestowing moral status on such living organisms on the basis of what we call sentience. And part of what sentience is, it's basically the ability to feel, to sense, and a large part of that is on how or if an organism feels pain. So, as I said, we can look at this question, can it feel pain, and use it to our advantage. As I said before, we can use it in taking advantage of how the major players in secular bioethics are sort of cornering the market of thought. And again, we can also claim the sort of scientific ground of assessing, well, how is it that we ascertain whether an organism feels pain at all? And this can be applied to the preborn, and I'm going to show you how. So in case to go back a bit further, because I liked how Dr. Johnson gave some historical context for his discussion of euthanasia. Here are a few key figures in Western thought that I think you should be familiar with. The first is Epicurus, who was probably the first known Greek philosopher to bring into play this whole utilitarian ideal. This is really what utilitarianism is. It's the calculus of a cost-benefit. That is to say, as living organisms, we seek pleasure and we flee or want to deflect painful experiences, and that's what the goal of an individual life is: to seek the most pleasure and to hopefully endure the least amount of pain. So, related to this, probably about a whole 2 millennia later, there was a prominent ethical thinker named Jeremy Bentham, whose ancestor in thought was then John Stuart Mill, who some of you may be more familiar with. But he as well took this whole, he's basically the godfather or grandfather rather of utilitarianism, whereby for a human being or for a collective of human beings, the most important thing, again, is the most amount of good and the least amount of badness, basically. And in his account, before Mill came along, his account was also a pleasure-pain calculus. So all of this to say that utilitarianism is still alive and well and taken up by other champions. And I think you should all become familiar with the person on the bottom, who's Peter Singer, who's incredibly influential in secular bioethics, and who, is many of us in the pro-life movement or who are concerned about this will be familiar with many of his writings. And even the average person will be, because they're astounding. They're astounding but logically consistent writings. So he is a utilitarian philosopher who, again, espouses the importance in determining a good life as one that is maximizing, again, the most amount of goods or pleasures and the least amount of pains. And he was actually the father of the animal rights movement. He underpinned, a lot of his writings underpinned basically why it is today most of us are, you could almost say, bombarded to some degree with concern towards how animals are treated. And again, there's good reasons for this, but it's gone a bit too far in the sense that now that pig or that dolphin that I've shown you, he has made the equivalent of an individual infant in terms of degree of sentience. So if you go back to what I was saying before about moral status, it's philosophers like Peter Singer who have brought to the mainstream the idea that an individual infant human being is no more, no less important than, say, a pig, a dolphin, a dog, in terms of the degree of sentience. And again, so this, if he's brought us all to consider the pain and welfare of animals, this can also be used in this whole abortion debate. Because if we can establish that the unborn also feel pain, then we've got another wedge into the argument as to why we should limit or restrict abortions. And this is exactly what's being done by pro-life congressmen and women in the US who've been successful in bringing about pain-capable legislation in their respective states. So this, I can't underestimate the importance of this. So one part of the argument is acknowledging society's deference to science, and in some ways I say we should call it scientism. I think we're all as part of the medical community. We shouldn't have to explain ourselves, even if we're of a particular religious, philosophical or ideologic persuasion. We shouldn't have to convince other people that just because we're pro-life, that we're not in favor of science. But the push of science as the sort of the only defining rationale for many of our legislative attempts is gone a bit too far. So for example, now that we've established that the human life, the unborn, the preborn, are actually human life, the pro-abortion side now shifts the goalposts and says that, well, we just can't establish when human life begins. It's not a scientific issue. So we have that on one side, okay? And on the other side, we have, and I'm in pediatrics, and as a developmental doctor, I talk to my medical students and residents about the importance of the environment in utero, and there's no doubt about it, our society is kind of split. There's a split personality. In one sense, we deny the humanity of the unborn, we deny the personhood of the unborn. On the other hand, you have a whole marketplace that's full of basically providing us information on the importance of a pristine in utero environment, giving the unborn stimulation. We have a toy market that capitalizes on what the preborn are actually capable of seeing visually. That is, they see contrast, checkered patterns preferentially. They see faces preferentially. If you play Mozart to your child in utero, you're setting up certain auditory memory patterns. There's a whole science that I'm not even going into that looks at preborn life and legitimizes the importance of setting up the best in utero environment for that child. So again, just pointing out there's no meeting of the minds in this regard. We just have to show people the connections here, and people just aren't seeing the connections. So this is where the pain issue as one piece of the puzzle comes in. We can give them a science, hopefully, that they can respond to. Does anyone know who this individual is? Bill Nye, right. So Bill Nye, the funny thing about Bill Nye, he's now a champion, I guess, against us unenlightened people. He's gone and redacted several of his videos produced in the 90s, one of which discussed basically the beginnings of life, when it began. So he's edited basically some footage from that discussing how life begins. He's also edited, as an aside, some footage on the science of sex and gender. So this is a scientist's response to scientific reality. But the reason is, again, because Trump comes in, science is being eschewed supposedly, we're members of the far right supposedly, we don't respect science. This is why, again, I'm pointing this out because when you discuss pain, as I would, as a neurologist, for example, I mean, people can't argue with these facts. Or they can, but really they're not standing on good ground. So the questions that I want to explore: can the human fetus feel pain? How would we know if they could? When would this capacity begin? And what fetal structures and functions support and affect this capacity? Now, and again, I want to say here at the outset, it's not my intention just for us to go over dry diagrams. And if I go over these diagrams a bit quickly, I don't want anyone to worry about not capturing the subtleties, because I want to paint an overall picture here. And if you want, I'm sure these slides can be made available if you want to go over them in more detail. Okay. And also the whole idea of trying to establish the science of pain and pain existing as a sensory experience in the fetus is, again, to say, well, you could throw out the question, should anesthesia be done during a second trimester abortion or third trimester abortion? And you'll have people scratching their heads about that. Because one thing I will also get to, if there's time, is the fact that there are surgeries taking place in the late second trimester and third trimester to help such children who have certain congenital malformations. And this is a big issue in anesthesia, is how do we administer anesthesia, not simply to protect the woman during the surgery, but also are we actually are we dealing with the pain needs of the unborn as well? Okay, so we're going to try and go over the history of fetal pain research very briefly. And I also want to bring across to you the difficulty in defining pain for anyone. Dr. Johnson just went over, the conflation, I think, of the experiences at the end of life that bring people to consider assisted suicide. And, it's never clear, or I should backtrack. I think it's always clear that it's more than just the physical pain of a particular condition, that there's an existential issue, there's a lot of other factors, subjective factors. So this is with any adult, any person experiencing pain. There's a lot going on, and it can't just be attributed to the physical condition itself. Very quickly, we will touch on certain aspects of anatomy and physiology, and also to understand pain expression, experience, and measurement in the fetus and neonate. And if there is some time, we'll talk about sort of higher consciousness functioning in the pain experience. So I want to approach this, as I said, as an argument and objective-based approach, because it can be a dry lecture, if you want, on looking over the various structures that subserve our pain function or pain understanding. So the first thing is to establish that, if we're going to research pain, how do we do it? How do we research pain in the unborn? Well, a good proxy or a good surrogate model, I guess to say, would be that we have premature babies who are simply fetuses that are now viable and living outside the womb. So we can look at the science in this regard. We can look at the experience here. There are premature babies who have surgeries and they need anesthesia. So we have pain specialists who have done a certain amount of research in the premature child. So we can look to their research as well. So I think it's safe to say, and I'm going to take this as a given, that we can really learn about fetal pain by looking at the premature baby experience. So I'm not going to go over this argument much. So here's a picture, a sonogram. I think this is a child of about 24 weeks. There's the sonogram of a child in utero at 24 weeks, gestational age, and then there in the NICU, in the little isolette, is a 24-week baby. So they're not the same baby, but they're at the same gestational age, okay? Okay, so we have 3 trimesters. We have, at one end, we have conception, and then we have birth. So we have 9 months. We divide up into trimesters. If you look back in 1973 when Roe v. Wade established the right to, well, I guess privacy, this is a discussion for another day, but fetal viability at that time was 28 weeks. And although the Supreme Court judges in the US, they said that the states were allowed to express an interest in supporting a child beyond the age of viability. So that is to say that they allowed or permitted the states to legislate on behalf of babies in the womb beyond 28 weeks, since that was the age of viability. So I'm going to show you how we've advanced. So that's 28 weeks in 1973. I'm using US because Canada doesn't, there's nothing in terms of, it's a vacuum, really. There have been a number of cases in the US which are fine, or I think I recommend everyone read them. They're interesting cases to show the vacuous nature of the legal reasoning. But in Canada, we don't have anything similar that has any interest or even points out age of viability as being possibly a consideration. Okay, but I want to focus on this second argument. It's got a number of premises. All of these premises are what we call empirical. These are premises that we can establish scientifically. And if they follow, then, or rather, if the conclusion that I'm going to mention on the next slide, if these premises are true, then the conclusion must follow, which it has in the US, and that's why, again, there is successful legislation protecting babies beyond 20 weeks. So we can establish scientifically that premature babies of varying ages show pain and stress responses, not hard to do. Premise 2, we need to counter the objection that many have that premature babies and fetuses are just underdeveloped human adults. And there's a few slides I want to show why that is not true. And basically, because the argument would be, if this is an underdeveloped adult, then this premature baby or fetus has an underdeveloped sensation of pain. That's really what the bias is. And I want to show how neurologically that is simply not true. And in fact, there may be the converse experience. There may be an experience of worsened pain sensation, okay, for a fetus or premature baby. And then the third premise is simply one of neuroanatomic development, that nociception, that is, all nociception is a technical medical term for sensation of pain. It's not the pain experience, it's simply sensation of pain is intact from early gestational life from basically 20 weeks gestational age. So the conclusions would be, if all of the above follow, or all of the above were true, that we need to care about analgesia, about an anesthetic if we're doing any intervention on mother or preborn, and that also abortion causes any of the following three issues: a stress response, a nociceptive pathway activation, pain, or all of the above. Okay, so as I said, we're going to explore this second argument. So the whole ball got rolling in terms of the study of fetal pain back in 1987. This was a neonatologist who had a cadre of premature babies who were undergoing surgeries. But at this time, those babies were operated without any anesthesia. So what, I believe it was a he, what he did with his group was looked at what we call the sympathetic response, the fight or flight hormones that were basically pre-existed the surgery, during the surgery, and after the surgery. And he also used a few other measures that would served as proxies for pain, and found that the response was rather intense. And he also, the beauty of his studies were that he looked at long-term outcomes. Just like as a developmentalist, I look at, what are the outcomes of a child who, has a stroke, or what are the outcomes of children with autism? Well, he looked at those that did not get pain treatment had poorer health than those in another arm or of some other studies did receive anesthesia. There were poorer health and development outcomes in these children. And this led to kind of the gold standard, like his research led to basically a complete about turn in the areas of pediatrics, neonatology, and anesthesia. So in the Lancet, the New England Journal of Medicine, at that point, all hospitals changed their procedures. All premature babies had to receive anesthesia during surgeries. And again, these would be, if this is the mid-'80s, these would be babies, that could be anywhere from 25, 26 weeks onwards. Okay, now pain, as I mentioned before, is complex. We have basically the subjective experience of pain, but also we have the neurologic or physical substrates of pain, and they're kind of two different things, or they're two different things that work together. But we have to, I think we can consider the possibility in premature babies that not only could they feel pain, but we also have to consider that even if we can't establish a subjective experience of pain, which requires consciousness, memory, even if we can't establish that, we could possibly establish the fact that the child has well-developed nociceptive structures, and therefore there is pain, there's the nociceptive experience without the subjective component, okay? So that's why I want to just draw the distinction here. So again, as I said, nociception is sensation. It's everything about the physical activation of specific pathways without the subjective experience of pain. In fact, many adults, children who've had spinal cord injuries, they have nociceptive experiences below their level of lesion. So if their lesion, is mid-thoracic, they will have, they can't comment subjectively on the let's say, the fact that their foot has been in contact with a piece of glass, but everything works apart from their subjective understanding or experience of the pain. So, as I said before, the pain in its totality, though, is also partially a subjective experience that involves emotions, higher cortical functioning, and may also be itself modulated by our past history of emotional pain, of our emotional state at the present. Are we depressed at the time that we're having the pain? Are we anxious at the time? And also life experiences affect our expression of pain and our subjective reading of how painful is this particular experience. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So there's a few things, though, that in this definition that don't necessarily apply or are difficult to apply to the preborn human being. First of all, the use of the word unpleasant, again, is a verbally described subjective adjective. It's something we could never claim a preborn child or a premature baby is part of his or her pain experience. The issue of potential tissue damage. This particular segment of the definition implies that previous experience and learning also affects our experience of pain, which is true. But it's hard to say, well, how does that apply to the preborn human being? And of course, just any time we use the word pain, we're talking about usually a verbally expressed experience. We cry out. Some of us use expletives. There's certainly part of the adult human pain experience or child pain experience that would be different than the preborn or premature. But I think there are still nonverbal ways we can look at pain in the preborn human being. And this is where sort of neurology comes in. There are physiologic markers. We can use EEGs, evoked potentials, functional MRI. There are other ways of looking at how pain basically starts from receptor and ends up in basically the physiologic output of pain, behaviorally and otherwise. So as I mentioned, obviously the preborn can't verbalize. They have often unspecified motor reactions to pain, whereas we might shoo away a bee that's stinging us or a mosquito. The preborn, or even your average newborn infant, has basically mass motor reactions. There's nothing specific that would demonstrate that there's pain localized to a particular region. There's also the reactions are reflexive in the neonate or the preborn human being. They're not consciously perceived. And also in the world of pain medicine and pain management, we use subjective scales of pain intensity. We kind of use like a Likert scale. In the world of pediatrics, we have a Likert scale that uses sad face or a screaming face to a happy, joyful face, and the child is supposed to indicate with his or her finger where exactly they feel they are in that. And this is how we gauge pain, again, in completely subjective experience. So it's funny when someone in favor of abortion at any stage says to someone like myself, well, we can't assess pain very well. It's just so subjective. I mean, and therefore we should throw out the whole issue. But meanwhile, there's a complete industry of pain management. Many of us right now, we're dealing with the whole opiate crisis, and pain as a human experience is incredibly important to get under to get at medically and to understand as best we can. So for people to say we should throw it out where the preborn are concerned is just ludicrous. Okay, But I think we need to focus on nociception here. We have to establish that neurologically, are the nociceptive pathways intact, at least intact, if not, possibly overactive. I think that is the minimum we need to establish, and that is actually what's been established in the United States. I'm just going to keep going while the slides come up. So there's a bunch of different factors in our pain experience. The whole issue of age affects how we perceive and express pain, how motorically mature we are, the integrity of our anatomy or neuroanatomy, the integrity of our endocrine and autonomic systems, our ability to communicate, our intellectual level to begin with, and that also implies sentience, as I said before, and also, as I said, our prior experience. So this is just a little schematic, and all I want you to get from this really is that on the top there is the cortex, truly what makes us human and rational. Down below is the spinal pathway. We call this the afferent spinal system. So, we have a noxious stimulus, and think of nerves as just the train route. So this noxious stimulus will travel and travel a nerve, meet in the what we call the dorsal horn of the spinal cord. So that's the sensory part of the spinal cord. The ventral horn, or towards our stomachs, I guess, is the motor part of the spinal cord. So the important thing here is that nociception, depends on the integrity of the spinal cord and the peripheral nerves. But pain depends on the integrity of everything above the thalamus. But I'm going to talk to you in the next few slides to show that in the preborn human being, cortical development is not as important for our ability to assess whether or not fetuses have an intact nociceptive system. Okay. Basically, this is really what I've just talked about. And again, don't worry about the specific parts. We have input structures like pain receptors and the nerves to our spinal cord. And then we have processing structures like our hypothalamic pituitary axis, our amygdala, which is sort of a memory, emotion, pain area. And the thalamus is probably one of the most important subcortical structures, because this is where we're finding that this is the minimum higher brain area that must be present in order for a pain experience or nociceptive experience to be had. So it's not that we need a cortex, because there are babies actually born without cortices that still have pain responses. And these are babies with what's called anencephaly or hydranencephaly. So they're missing these upper cortical structures. But there have been studies on adults who've had brain injuries and unfortunately have most of their cortices destroyed, yet they're showing all the signs of a pain experience because they have completely intact nervous system from the thalamus down. Okay, so that's really what I want to drive home. Okay, I don't want you to get hung up on other neuroanatomical structures. So I'm going to go through a few objections, something that people on, I'll say, the other side will throw at someone like myself who has an interest in fetal pain. The first objection might be, well, they're immature. There's no way that a nociceptive pathway can be functional. And their assumption is that basically the pain pathway in this fetus must be the same one that adults use. But it's really interesting. If you look at the embryology development, the embryo and fetus, in order to stay alive, it uses pathways that sometimes do not end up being the pathways that we use as adults. So in the nervous system of the developing fetus, there are parts of the developing brain that are actually used in different manners, different capacities than we eventually use in later on, later stages. So that's something that's only been recently understood. It's amazing how flexible the nervous system of the fetus is. So basically, this response that someone like myself would give really gets at the fact that fetuses are not simply tiny adults, and just because they're tiny adults, that their brain systems do not work. And I'm going to show you why right now. First of all, the pain generation, we have specific pain receptors on many of our body parts, on our skin, but the young fetus basically has, for all its cutaneous receptors, all of those receptors are pain-transmitting receptors. So whereas we have more specialized, we have like 5 or 6 types of cutaneous receptors. We have pressure-sensitive receptors, we have temperature-sensitive receptors. Well, the fetus has generalized receptors. So basically, all of their receptors are transmitting pain, as opposed to so we have a limitation of how much pain we're able to transmit by virtue of limited number of receptors. The fetus, on the other hand, uses all those receptors to transmit pain. As well, their skin is incredibly thin. These nerve fibers, so for example, if you took a shard of glass and just tapped your hand, a little bit of pain. Well, that's because our skin is very thick, to the point at which it hits the receptor for pressure and a sharp sensation. In the fetus, the skin is like saran wrap thin. All those nerve fibers are right pressed up against that skin layer. They're penetrating the skin. So again, this is another area where the pain actually is more likely to be sensed because there's less inhibiting its sensation. So it could be that the fetus actually has evolved more refined nociceptive structures. Yes, and the last point I want to just bring home is that the receptors themselves are much more densely configured per square inch. So if you can think about our surface area, it's pretty expansive. But with the fetus, there's very little surface area. So all those receptors are much more densely configured. So I've just mentioned 3 reasons why we can consider the fetal nociceptive experience to be more intense than an adult. Now, a second objection might be, well, we're fully myelinated human beings. So what is myelin? Myelin is kind of like, as you know from medical school, if you've done your neuroscience, it's kind of like the insulation on a wire. It's what allows the nerve impulses to travel quickly. And so the argument from the other side might be, well, an undeveloped baby or a fetus, they don't have myelinated pathways. And that's just an electron microscope pictograph of myelin, basically that more dark circle coating the nerve cell there. But the whole issue, what's being forgotten, and a response that you could give would be that the fact is that pain in the adult is not carried through myelinated nerve structures. So we have a lot of myelinated nerve structures, but that which carries pain is unmyelinated. So this argument doesn't even hold. Or the myelinated fiber that does carry pain is very thinly coated. So again, all it implies is if at any the only thing you could claim with this argument is that the conduction velocity is slower. But again, in an adult, we have slow conduction velocity of pain. The other thing you could claim in response is that there may be an offset because there's very little distance to travel in the fetus compared to an adult. So really, speed of travel of impulse is really a non-issue. The third response you could give is that although, again, as a human being, our nervous system isn't fully myelinated until actually our mid-20s, what's important is that the nociceptive fibers in the fetus, or that is to say, the nerve tracts in the spinal cord, up to the thalamus in particular, are basically myelinated by the second or third trimester. So again, another basically another way of combating that claim, which is it's a very cursory generalization given by the other side. Okay. The other thing is that another objection would be, well, the fetus in general, its nervous system is immature. So wouldn't you just stand to reason that their input, the pain input, the nociceptive input is diminished? This is just a picture showing how far we've come with our understanding of pain. On the left corner there, top corner, is our previous, pre-Enlightenment understanding of pain. What pain was thought was it traveled one way. There was, you'd get a noxious stimulation of a receptor, it would travel and be processed by the brain, and then there would be a motor response. But now we know that there's a lot going the other way, what we call descending inhibition. You've all heard about possibly you've heard about serotonin and our opiate receptors. These are, especially in the brainstem, and what's called the periaqueductal gray area around the spinal cord, the central canal of the spinal cord. So basically, as soon as pain happens, our brains are modulating it or trying to inhibit it. So there's an afferent system that is coming up to our brain, and there's a descending or efferent system. And that is, and the descending system is throwing, for lack of a better way of saying this, throwing serotonin, the feel good or the peace of mind type of neurotransmitter, and opiate and endorphin and other opiate type neurotransmitters at the pain response to try and deaden it. So we have this built in. There's this efferent response. So the thing that I want to mention, and basically I'm going to bypass this because, again, I don't want us to get hung up on details in limited time, but the whole point to say, and sorry, this is a slide of periaqueductal gray. The whole point is to say that, that I'm going to say in the next few slides, is that the immature fetus does not have a mature efferent pain system, does not have an efferent pain modulating system like we do. So there's a real chance that they're not able to deaden the pain as our descending systems are able to. The other response that I have to this is that although there's a lot about the child's brain, the fetus's brain, that is not well developed, that is to say, cortex is not well developed, our neurochemistry as fetuses is well developed. Everything is there. Okay, I'm just going over this quickly. All our sort of lock and key, you have the transmitter, you have the receptor, you've heard about that lock and key, key and lock analogy. Well, the fact is, when we've done autopsy studies on the preborn, everything that is involved in looking at the opiate system, all fetuses have the receptors in place. Okay, we have opiate receptors in tiny babies preborn. The problem is that those babies yet do not have the descending input. Okay, so they've got receptors waiting, but they don't get the chemicals to come in as keys to the lock. So there's a problem there that we think they're not getting the pain deadened as we would, okay? So, guys, I have a few more objections and responses, but due to lack of time, I'm just going to leave them here for your perusal. Again, I hope the slides will be made available, or this will be here, because there's a lot we can say in terms of helping our colleagues understand about how pain is processed in the fetus. So what I really want to do is just go to my summary slides. So really what I want to say, that the ability to feel pain and respond to it is just not something that comes to us as soon as we're born and delivered. The other thing I also want to bring home is that we have to think not just of our subjective experience of pain, but try to imagine that in the fetus, everything to do with nociception is either present or is immature, but more likely from the standpoint of pain, I guess a pain-relieving part of our neuroanatomy is not present, okay? If you want to sort of pin your thoughts on what age can I say with confidence that a fetus should be protected from pain? I think it's safe to say with the literature now that exists in anesthesia, neurology, and neonatology, that 20 weeks gestational age is a cutoff at which point it is reasonable to claim and argue that every child, every baby, every preborn after that fact should be receiving anesthesia for any intervention, may actually need more anesthesia than what's currently being provided to mothers, because obviously we have the mother's pain needs to take care of, but any intervention we have to look at the needs of the fetus as well. And then this, of course, brings up the question about abortion after 20 weeks. And the experience that's there. Because everything is there. There are a few missing parts, most notably in the areas of trying to deaden the pain for the child. There are markers of fetal pain perception starting at the 7 weeks gestational age, but again, everything is there likely for nociceptive experience at 20 weeks, okay? So, I'm sorry, a lot of this is rushed, but there's a lot here if you want to read about it. Maybe I can divide this into two parts next time I do it. But maybe I'll stop here, and some of these other objections might be addressed if you have questions. Thanks.